Hi, everybody. Hi. Thank you, and welcome to our second program here in the great state of Georgia, here in Atlanta. Thank you again. So this is also our 23rd program of the year. Last year we did 31 programs as an entire year, and right now we're not even halfway through the year, and we're at number 23. This is a great thing. And again, why? Because we know there's a need. There's a fabulous need out there for the many that need to learn and be educated about multiple sclerosis and the topics, the symptoms, and so on and so forth. We want to be able to make sure that people are being educated and they're getting the resources and they know where to find the information as well. That's why we do these things. And about MS Views and News, for those that are new to our program, yes, it's our second program, but many of you have seen or heard about it, whether it be on Facebook or Twitter or LinkedIn, or maybe you've seen our newsletter. You get our newsletters. I know you get it, or just recently got subscribed to it, and you see the information we put out by newsletters. We've only been doing this for 5 years. And since our first program in February of 2010, we are into doing over 90 programs already. Okay? That's great. Don't you think so? Yes. Thank you. Unbelievable. So, MS Views and News, we have our blog, we have our website. For those that have never visited our website, there's a long list of items there on the first page that have topics that many of you are quite interested in or knowing about. You could click on any one of them. It opens up to the articles. If you don't see it on the front page, there's a search box at the top of the screen. You type in one word, bladder. You type in one word, memory. You type in one word, optic. Whatever it is, one word. Click on the enter on your button to enter, and it'll open up all the articles that can be seen from there. We also, at the top of this, which I can't get to right now, but the top of this website, there are different things that if you put your mouse on it, scroll down boxes appear. And on there, you can access our YouTube channel. You can access the blog, our blog archives, our newsletter archives, the Blog Talk Radio that we have. We do Blog Talk Radio, in case you didn't get it by me saying Blog Talk Radio. Facebook, we have 7 different pages on Facebook. We have a caregivers page. So if you have caregivers that you want them to be able to communicate with other caregivers, then that might be the place for them to go to. You can write to us and ask us if you don't know how to access that on Facebook. We have a page for people with SPMS or PPMS for them to communicate with each other. We have a page for just friends of Stu's Views and MS News. And by the way, that's how this all began. Stu's Views and MS News came about 15 years ago. And then it became MS Views and News. But on Facebook, very important social media. Dr. Oz gave me nomination and awarded me just 2 months ago with being one of 10 in all of the United States on social media for multiple sclerosis. So the bottom line is, though, MS Views and News wants to provide education, information, and resources, and we want you to use what we have. And I could go on and on and on, but we don't have time for me to speak all day today. So right now, though, I want to ask, we have support group leaders that are here, and we do ask support group leaders, wherever we do programs, to come and speak for you for 90 seconds each. So I would like to start with Susan. Susan came from Birmingham. And the reason why I like to have Susan come from Birmingham and be places, because her husband back there is doing photography. So we want to have Susan come on up. You're going to come on up? I can't bring the mic to you. You said you wanted to come up here. So we want to welcome Susan from Birmingham, Alabama. Actually, I lie. She's from Tuscaloosa, Alabama.
Well, I'm originally from Birmingham, but I live in Tuscaloosa, and I'm the support group leader in Tuscaloosa. And I tell people, when I was first diagnosed 15 years ago, that my neurologist did. Oh, I sound loud. Yeah. My neurologist at the time said, "Don't go to a support group meeting. They'll depress you." And of course, you know, like most people with MS, I was sort of in denial, for a while. We moved to Tuscaloosa, and one day I thought, well, I'm going to go to one of these and just see, and enjoyed it. And I tell people that MS is such a complicated disease, and no two people are the same, that you get in a group like this, and somebody will have had that same symptom, and we can all talk about, we're all on different drugs, so we can talk about, I've had this problem with this drug, and so it's an educational thing, and I was diagnosed 15 years ago, and I'm still learning. There's a lot I don't know about MS, and Stu is going to try to expand into Alabama soon, and I'm really looking forward to it. I had been following him for years, and he had the first program in Alabama back in April and enjoyed it, and so we decided we'd follow him on to Atlanta. But anyway, I hope everybody enjoys it, and I hope to see you again.
Thank you, Susan. Thank you, Susan. All right, next we have Tawanda. Tawanda, I think you came up from like Central Georgia somewhere. You could tell them when you get up here. How's that? But you're going to have to run. We're running out of time. Uh-oh. Wow, she wanted to be visible today with all that lavender.
Why, thank you. How's everybody doing? Okay. As I've been introduced as Tawanda Cooper, we have our group is up in Northwest Georgia, around Cartersville, Bartow County, and we meet on the fourth Thursday of every month up in Cartersville. I mean, you don't necessarily have to live in Bartow, but you can come and join us, and we would appreciate it if you do. I'm over here on this side, so if you need my business card, I'll be glad to pass it out to you. 90 seconds or less.
Wow, that was good. That was good. She just helped make up for those that go over. All right, next I have to bring the microphone all the way to the back of the room. So while I'm bringing the microphone all the way to the back of the room, I just want to let you all know that we have great raffle prizes here today to give out. We have an Android tablet, and we have other things like different shirts, and we also have T-shirts that I'm going to show and hold up to you later on. It says, "I'm not drunk, I have MS." Who wants to be lucky winner of that one, right? Ladies, explain yourselves.
Thank you. I'm Robin, and this is Debbie, and we are the co-facilitators of a large support group at the MS Center of Atlanta. And we just didn't feel like we wanted to get in front of a camera today because, it's a bad hair day, so that's why we're standing back here. We are a group of women only. Sorry, guys, but, we talk about things that, we just like to talk about among women. So this is a women's support group. We meet the fourth Tuesday of every month. We start at 6:30 in the evening, and we're at the MS Center of Atlanta. You can just, look them up online. If you know where the OK Cafe is in Atlanta, we're real close to that. So it's real easy to get to us off of 75 and simple. We are a support group of women. We don't have speakers come. We talk to each other about what's going on. We usually pick a topic and spend part of our time talking about a specific topic that everybody agrees on for that particular month, and then the rest of the time we just talk about lots of open things. So we'd really like you to join us. I think we're one of the biggest groups in the metropolitan Atlanta area, and I can honestly say that some of my very best and dearest friends I've met at this support group. So we'd like you to join us, and this is one of my best and dearest friends. Say hello.
Hello, everyone. We would love for you to join us again, fourth Tuesday of every month. Starts at 6:30 at the MS Center of Atlanta.
Thank you, ladies. By the way, for those that don't know, do you know that I too have MS? It's tough. But you want to know something? My energy comes from doing for everybody else with MS. And that's where I get it from. So I will just keep on striving to do this. Our next guest is Vicki Pomeroy. And by the way, here's that other shirt, that "I'm not drunk, I have MS." I know a lot of you are going to want to win this one, right? You got to be a small, though.
Mine were sexier. Mine were cuter, too. What made you think that these women would be small?
Georgia.
I'm just sorry. I have a bad tendency of pointing out shortcomings in people. And why would he come to Georgia and only bring size small?
Because I didn't want to insult anybody with extra large.
No, honey, we're voluptuous. Anyhow, I'm Vicki Pomeroy. Many of you know me over the years and all different things. I sat on the board of the GRC for the Society for 7 years. I run a support group that's been together for 25 years. I write a newsletter that now goes out to 83 different countries and 6 continents. Now, through the wonder of the internet, I found Stu's Views and News. 9 years ago? 10 years ago? Something like that. So Stu and I started communicating and everything. One of my strongest beliefs is that we need to know not just about one drug. We need to know about every single drug that's out there and available to us. We need to know about every possible treatment that's available to us. Our doctors, drug reps, other people, professionals, sometimes have a tendency to corral what they want us to learn about. And as MSers, and as someone who's lived with MS for 35 years, we don't want that. We want to know everything, because we have to find what works for us. It took me 8 years to talk him into getting out of Florida. He finally came up. And besides expanding into Birmingham, we're also now going to be expanding into the Atlanta area. So we will soon have a local office for Stu's News.
Thank you. Thank you. We have one more support group leader that I didn't know about was here today, but she wants to just speak from over here.
Good morning. My name is Rosalind Bird, and I am a co-facilitator at the support group at Green Forest Community Baptist Church, and we meet on the second Saturday of every month from 10 to 12. And we're a group of individuals that come together to share. And like someone else said, our group, we don't have a particular topic. We come to share whatever is on your mind at that particular time, or whatever complications, problems, or just concerns that you may have. And we're welcome for everyone to come and join us. And the one thing we all say, what stays in our room, what we talk about in our room, stays in our room. So that's the confidentiality we have for each other and what we consider ourselves as family. So second Saturday, every month, 10 to 12 noon. Welcome.
Thank you. Okay, real brief before I introduce our speakers. I want to thank Teva Neuroscience for providing us with the funding to do today's program. The MS communities need to know how important it is for MS Views and News to be able to provide educational programs. Yes, we rely on the pharmaceutical companies. Why? Because where else are we going to be able to get the resources to provide these kind of programs? So for those that do not know, yes, Teva is giving us the funding to do today's program, and I personally want to thank Teva, and I hope you all do too. For those that do not know, Teva Neuroscience is the manufacturer of Copaxone, and you'll be hearing about this from our speakers today as well. In addition to Teva, Accorda Therapeutics is a sponsor. Accorda makes the Ampera. Biogen IDEC has Avonex, Tysabri, and Tecfidera. EMD Serono, Rebif. Genzyme makes Aubagio. Novartis has Gilenya. And Questcor has Acthar Gel, and Acthar Gel is used for MS relapse. And again, for each of these medications, many times people don't know who's making that medication, so we just like to let you know this as well. They are our sponsors. We do appreciate everything that they do for us, because without them doing for us, we cannot possibly do for you. So thank you. Today, Dr. Jack Burks had to come up from South Florida, and even before I have Dr. Jack Burks come up, of course, many of you know why Dr. Ben Thrower is not here. Okay, Dr. Ben Thrower's son passed away last Friday, and I would like to take just 30 seconds of your time right now to just give tribute, honor, whatever you'd like to do. Think about Sam Thrower, 30 seconds. Thank you. Okay, let us continue, please. Thank you for that. Dr. Burks came for us from South Florida. For those that do not know, Dr. Burks is very well known in MS communities across the United States. I'm sure he'll talk a little bit about himself. We sent you his credentials on the paperwork that we had to resend out this week. You could read about it. Just go to our website, see about what he's done for the MS community. I don't want to take up too much of his time because Dr. Burks has to be out of here by 1:15 to catch his flight to get back. Also, in addition to Dr. Burks coming up and filling in and doing a great job, because we know he will, but also Tracy Walker could not speak, and in place of Tracy Walker, I wanted to ask somebody that I really, really respect, because she speaks a lot of our programs in Florida, and that's Patricia Pagnotta, and she's a nurse practitioner, and she'll wow you guys. I mean, I know she will. And if she doesn't, then you could all come and hit me, all right? But first, let's have Dr. Jack Burks come on up. Thank you, sir. Get comfortable.
Bill, you okay?
Do what?
Well, it's a real pleasure to be here, even this sad moment, for one of the best MS doctors in the world from Atlanta. And you're very fortunate to have Dr. Ben Thrower helping you with your multiple sclerosis. So I'm pleased I can substitute for him. I'll do the best I can. What I did in the last few days, since Stuart asked me, is I just put together sort of the ideas that I thought would be important to talk about today. And I've divided them into, as you can see, I'm going to just briefly talk about what is MS. You know what is MS, but there may be people new to MS that are here. There may be spouses or family members, just to get a brief update. Then I'm going to talk specifically about MS relapses or attacks or exacerbations. Then what everybody wants to know is, what about disease-modifying therapies? There are 10 approved therapies. There's probably 5 or 10 that will be approved in the next few years. There's about 30 in the pipeline. It's very confusing, and it's going to get more confusing. So I'm going to try to help give you a brief overview of the disease-modifying therapies. And then I'm going to talk about something that's really, the next 3 topics are really near and dear to my heart. I'm going to talk about adherence and compliance. And the bottom line here, if you don't take the medicine, it doesn't work. You think that's simple? I'll give you some data that will open your eyes about how big of an issue this is. Switching therapies. Switching therapies is a major decision. What do I start on? How do I know it's working? When do I switch? And what do I switch to? So we're going to talk about that issue, which is on the minds of many people with multiple sclerosis. And then I'm going to talk about how you can participate in the decisions about what's best for your health care. I want you to become the best consumers of your own health care you could possibly be. And I'll give you a strategy that I think is working very nicely, and maybe you can adopt at least part of this for yourself. And if we have time, I'll talk about what I consider a game plan for how to approach multiple sclerosis. I've been doing this for over 40 years. And so I've learned a little bit about talking to thousands of patients, and I'm going to share some of that with you. So anyway, since I was asked to do this just a few days ago, I outlined my talks, and then what I do, like most good speakers, I say, who are my buddies who have talks like this before? I can take some of their slides, so I don't have to make up my own slides. And I've used some of Dr. Brian Steingold's and Dr. Stephen Krieger's slides in this presentation, and I want to acknowledge them and to thank them. And for all the other MS experts who I've taken some of their slides from, thank you. My job here is to educate you with the best slides and the best concepts I can. So I'm going to start with a definition of multiple sclerosis. I'm going to do this quickly. I'm happy to answer questions when I'm finished, but I think most of you know this, and I want to get to the other topics and spend more time there. First of all, it's an immune-mediated disease. It's an autoimmune disease. It affects the central nervous system, which is the brain and spinal cord. Everybody here knows that. 85% of the people start with a relapsing remitting disease. People have an attack, they get better. They have another attack, they get better. And then slowly, after several years, they become secondary progressive if they don't get treatments, especially. This is the natural history of the disease. And then we have primary progressive, and it starts usually later, just a slow, gradual progression, usually with stiffness in the legs, maybe some bladder problems early on. It gets slowly worse every year. There's no real attacks. And the one thing I'll say about MS is no 2 patients are the same. The symptoms are very variable, and they can affect almost any part of the nervous system malfunction. So this is Dr. Brian Steingold's slide, which I just love. And so I'm going to talk about this slide. And MS starts with a trigger. And here, if you can see, it's the archer. The triggers are genetic, environmental, infection, and maybe others we don't know about. But this trigger starts in, and the arrow goes out, and it activates the lymphocytes. So the arrow is heading for the brain, but it has to activate the lymphocytes first. And then the lymphocytes have to get across the blood-brain barrier. This barrier that keeps bad cells out of the brain, somehow they've got to get into the brain to cause the damage, which is inflammation and degeneration of the brain. And this lymphocyte, we used to think it was just T cells being the cellular part of the immune system, but it's also the antibody part of the immune system, it's B cells, which makes this disease much more complicated, much more complex, much more difficult to treat, but also gives us another avenue to treat. So now we have other things that we can target to treat. We can now start targeting B cells. We're doing that now, and the results are outstanding. And you'll hear more about that later. So we have B cells and T cells affected. So the arrow goes through the blood-brain barrier right here and hits the target in the brain. We can stop it here, we can stop it here, and we can stop it here. And I'm going to talk about ways to do that today with a variety of drugs and lifestyle changes. Okay, just a brief overview. Did you know that more women have MS than men? We used to think it was about 2 to 1, then it was 3 to 1, and now some data are saying it's over 3 to 1 now. So we're seeing much more MS in women. And again, we said earlier that 85% start with an attack, 15% start with progression, and that there's early inflammation where these lymphocytes get activated against the brain, but later on it becomes more progressive disease, and the disease becomes less inflammatory and more degenerative. The cells just are dying without a lot of inflammation going on. So we have two processes going on. It turns out they're going on simultaneously. We just don't notice the degeneration so much early on because people are having attacks. We really focus on those. But now that we're understanding this, we're starting to develop treatments for the degenerative form of the disease. And what does that mean? That's for progressive patients. So I'm going to spend a fair amount of time telling you about new treatments for progressive MS. Now, we never talked about it. It was the neglected part of MS because we didn't have any treatment, so we didn't talk much about it. Well, today I'm going to tell you some things that are going to knock your socks off about what we're doing in developing treatments for progressive MS. So those of you with progressive MS, keep the faith. We're on our way. There's damage to myelin. We knew that. It's a demyelinating disease. But what we didn't know until the last few years is the axons are involved, the wires, that the myelin coats the wires. The wires get affected as well. And the neurons, the actual brain cells, the gray matter of the disease also gets affected. So we're discouraged that all these components of the brain are affected, but it also gives us better targets to develop our treatments. So we're developing treatments that will affect both damage to myelin, axons, and neurons. Cognitive effects. MS patients have cognitive problems, about half. They're not very severe usually. Forgetfulness, they're multitasking, and I'm sure Patricia's going to talk about the management of cognitive problems. But we do see cognitive problems, and it's important to realize that because there are things you can do about it, and you'll hear about that in the next speaker. There's a genetic component. Now, it's not Jerry Lewis's disease. Half your kids are not going to get MS. But the risk of MS in the general population is about 1 in 1,000. If you have a close family member, it's 1 to 2%. If you have a non-identical twin and you have MS, their chances is 5%. If you have an identical twin, it's 30%. So genes are involved, and those genes, in general, represent the immune system's regulation. So the genetics are part of the immune system regulation problem. Environmental risk. People want to know what's going on with environmental risk. This is a whole topic. This is a 45-minute lecture. I'm going to do it in 30 seconds. First of all, we see it mainly in temperate climates. We used to say, well, you can't have it unless you're in a temperate climate, but that's not true. We're seeing it worldwide now. Why that's happening, we're not quite sure, but you'll get some hint later on. But again, we see it more in temperate climates, but we also can see it in more tropical climates as well. Infections. We've always thought about viruses being involved, and the current virus in vogue is Epstein-Barr virus. It's the mononucleosis virus. It appears that one increases your risk for MS if you've had mono. I should tell you it's not sexually transmitted to spouses, so that's not an issue for us. Vitamin D, a lot of research in vitamin D. We know from studies that low vitamin D predisposes people to get MS, and that now we're saying, if you give vitamin D, will it help? And most doctors are now recommending vitamin D. I recommend you get a vitamin D level. If it's low, you make sure you get your vitamin D level higher. Smoking. If you walk away with one thing and you smoke, it'll be the last cigarette you ever smoke. This is a terribly deleterious effect to multiple sclerosis. If you have a history, if you're a smoker, you're more likely to get MS, and maybe you can't do anything about that. But if you're smoking today, you're more likely to get progressive of disease. So cigarettes are out. You're hurting yourself, you're hurting your family. So please don't smoke. We're learning about high salt. The second thing you're going to do when you leave here is don't be going, look at the salt content of everything you buy. These processed foods, these restaurant foods are full of salt. People say, well, I won't use my salt shaker. That's not the major source of people getting salt. It's the foods we eat. So fresh foods are the answer to this. It turns out that people who have a lot of salt in their diet have much worse multiple sclerosis. So keep that in mind. Hopefully that's something new for you to learn. There is some data just coming out that obesity, especially in young women, may lead to multiple sclerosis. And also there's a thought, you have to throw a little bit of really interesting stuff, is that maybe people who have good hygiene are more likely to get multiple sclerosis. What is that all about? Well, it turns out areas where there are lots of parasites have less MS. And there's a recent study from Wisconsin. It's a very small study, and it's just some preliminary stuff. But they actually gave patients parasite ova. And the early results are not conclusive, but it was useful that there may be some effect giving parasites. This came out of South America, with studies in South America, but parasites may be keeping people from getting multiple sclerosis. Or if they have multiple sclerosis, it may make the disease less sick. Now, I'm not telling you to go out and eat worms. But I'm saying we're learning about these sorts of things, about how things like parasites may have kept the world safe from multiple sclerosis, except for those of us who had good hygiene. Again, that's very preliminary, and that's a little tongue-in-cheek. But you want to know what's going on in MS? You want to know the latest stuff? That's the latest stuff. All right, this is what MS looks like. These white dots, that's multiple sclerosis. This is the brain. The skull is the white circle around. The insides are the lakes or the ventricles of the brain where the spinal fluid resides. And you shouldn't see these white spots. These white spots are abnormal. All these white spots, that's multiple sclerosis. This is in the balance center of the brain. There's a spot right there. That's multiple sclerosis. So now you've seen what multiple sclerosis looks like. When we want to do your MRI and you're wondering, what are you seeing on the MRI? This is what we see on the MRI. I'm going to do this. It's an inflammatory disease. I said that first. I thought you'd just like to see a picture of how severe the inflammation is. It's a wonder people aren't sicker, but it gives us a target to go for. And what we see here is a blood vessel. And here's normal brain out here. See how nice and light that is? All these black dots here, those are all lymphocytes surrounding that blood vessel, causing the damage of multiple sclerosis. And I thought you probably haven't seen that before. So this is what a lymphocyte infiltration, when we talk about inflammation, we're talking about the blood vessel and all of these white blood cells around it. And they're not out here, they're just around the blood vessel. So that's what we're talking about. That's our target when we talk about treating multiple sclerosis. I'm going to take a few minutes and talk about MS relapses, because we almost never talk about MS relapses. We talk about the disease and disease-modifying therapies. Well, MS relapses are a really important part of the disease. Understanding them, knowing what to do about them. So I'm going to take just a few minutes to talk about those. All MS, or 85% of MS, begins as a relapse. They have an attack. First attack, that is what we're going to be talking about. And then they have recurrent attacks. And those are called relapses. They're called exacerbations. They're called flare-ups. They're called attacks. Whatever you want to say. They all mean the same thing. And that this is the acute inflammation. That blood vessel I showed you, that was during an attack. Okay, that blood vessel is being attacked. The brain around that blood vessel is being attacked. So we're talking about acute inflammation damaging myelin axons and neurons. Where? It can go anywhere in the brain. Anywhere in the brain. So therefore, the symptoms depend on where the inflammation is. If it's in the connection to the eye, you may have decreased vision. If it's a connection to the balance center, you may have decreased balance. Basically, every symptom that you can imagine can be part of a relapse. But it must last more than 24 to 48 hours. So we have to establish that there's active inflammation, because I'm going to show you a slide in just a minute where it looks like an exacerbation, but it's not. It's called a pseudo-exacerbation. But for us to say the patient's having an exacerbation, it can't be, I felt badly this morning, so that's an exacerbation. And I have people who come to me. So I had 16 exacerbations in the last 3 months, doctor, because I woke up 16 times feeling like terrible. I was better by noon, but that's not an exacerbation. It must last a day or two before it's an exacerbation. And if your child refuses to take out the garbage for you, because it's good, you need the exercise to take out the garbage, Mom, so I'm not going to take out the garbage. I'm going to help you by giving you more exercise. And you get upset, and you feel terrible, and you're angry at him for 3 or 4 hours, that's not an exacerbation. So you can't accuse your kid of causing your exacerbation. It has to last for a day or two. And they usually improve over weeks, occasionally months, but usually they don't last a terribly long time. So there are treatments. And moderate to severe exacerbations are treated usually with steroids, either given intravenously. So anyway, you can either give it intravenously, which is the standard way of giving it, but some people are now giving it by pills. You have to take a lot of pills, but it can be done. And then for people who don't tolerate steroids, or they're not working, they're not getting over their exacerbation, there is a relatively new drug that's very old, that's coming back. It's called Acthar, it's ACTH, and it actually works the same way the steroids do, but it may have other properties as well. And I'm not going into it because it's not the focus of today, but there's something about melanocortin. It has a different kind of hormonal activity that may help people that steroids don't help. So it's a tremendous boon to us to have this second drug that we can use, a second way to treat exacerbations. And if you don't know about it, ask your doctor about it. It's about when to use it, etc. It's given by a small injection, and it's not given intravenously, so you don't have to worry about that, and it's tolerated really well. And then the people who don't respond to either of these, we still have plasmapheresis, and that's basically you take the blood out, you separate the cells from the serum or the plasma, and then you clean the serum and the plasma from these antibodies that may be causing the destruction, and you put it back into the body. And that's how plasmapheresis works. Am I taking questions now, or are we going to hold those questions? I'm sorry. I think they want to hold the questions. So I'll finish, but don't forget your question, please. So anyway, so how do you treat the symptoms? And how do you treat your functioning ability when you have them? Well, first of all, I really recommend patients who are having at least moderate to severe attacks rest. Get in a cool place. Don't push it. Take care of your body during this time. Let your body recover from the inflammation. And then if you're having MS symptoms, they can be treated often with medication, or they can be treated with rehabilitation. If you're having trouble walking, maybe the physical therapist can help you. And it's a good time to really get educated about MS, because it makes you think about what this disease really is. And often people need psychological support. The anxiety that relapses create is significant. Sometimes it can create depression. And so don't forget to try to get psychological support if that's what the situation calls for. Okay, now what if it looks like a duck and quacks like a duck and walks like a duck? Is it a duck? Not necessarily. It may not be an exacerbation. So my job as a neurologist is to say, is this a real exacerbation or not? And one of the things we find very frequently is the patient's having a urinary tract infection. And the urinary tract infection may actually be mild or may not have any symptoms. But we test the urine, and often we find the urine's infected. So we don't give steroids. We actually give antibiotics to treat the urinary tract infection, and they don't need steroids. So it's important that your doctor look for what we call pseudo-exacerbations, because they're not caused by active inflammation of the brain. They're caused by a stress on the body from inflammation or from overheating or psychological stress. And so the treatment for that is aimed at the underlying cause, not steroids. So I think it's important to try to differentiate what's a real exacerbation and what's not. And that's one of the reasons why your neurologist can be very helpful, because he's trained how to do that, or she's trained how to do that. All right, the types of MS. Well, the standard is, well, you have relapsing remitting, secondary progressive, primary progressive. Those are the three standard. But the fact is, we have a few more things to think about. One is called a clinically isolated syndrome, and that's really the first attack of MS. And you now can take the first attack of MS, look at the MRI, and in some situations, make a diagnosis that day. So you don't have to have multiple attacks to make a diagnosis, because we're using the MRI to help us. And then there's something called radiologically isolated syndrome. These are people who've never had an attack, never had a symptom. They get bumped in the head in an automobile accident, and they get a head MRI, and all of a sudden they look like they've got MS. Or they're going for a fertility workup, and they find out they have MS-like disease in their brain. Was this really MS? It's not an attack. They've not had any symptoms. But what we're finding is a lot of those people go on to having MS. And now that we're getting new treatments, and we're trying to push early treatment, there are some doctors who feel that the patients who have MRIs that look like MS, even though they don't have symptoms, should be treated. That's debated. I don't have the answer for that, but there is an increased risk if you have an MRI that looks like MS that you will develop MS. And that risk is getting more and more recognized. All right, so when we give disease-modifying therapies, I'm going to talk about treating this inflammation and treating the progression. So what am I looking for in my therapy? What do I want my therapy to do, ideally? Well, first of all, I want it to knock out the activation of the immune cells. With that second part of Dr. Steingold's error, those are the lymphocytes. We want to knock those out. We don't want those around. Second, if we can't knock them out, we want to keep them from getting into the brain. Put them in the lymph nodes, or at least just stop the blood-brain barrier from leaking and letting them into the brain. That's another goal of ours. We want to reduce the immunologic activity in the brain. So even if they're in the brain, is there something we can give that can actually stop the activity in the brain? We want to increase myelin repair. Myelin's been damaged. Let's find a way to make it better. There's some exciting news later on in my talk about that. And then we not only want to repair it, the stuff that's already been damaged, and we want to make new. We want to make new myelin. We want to make new axons. We want to make new parts of the brain. And I'm going to have a little talk about stem cells in a few minutes and to talk about some of that stuff. But there are other ways to do that as well. What is our goal? We want a disease-free state. What does that mean? You'll hear more and more about the term disease-free state. That means, first of all, no relapses. Done. MRI, no more MRI activity. And no progression of disability. That's what we really want. So if you're wondering what I look at as a neurologist, at my goals when I'm treating patients, and should be your goals, this is what we want out of medications. So why are we pushing early treatment? We're pushing early treatment because of what we're learning in the science. And what we're seeing is that there is ongoing myelin damage, even early on. We used to think you had an attack, you got better, you were better for a year, bam, everything was quiet. That's just not true. This is a continuous myelin damage disease in most patients. And that's scary because we thought, well, you're doing okay between attacks. Well, you're doing okay clinically, but your brain's not doing okay. And so that really bothers us. The second is that we just thought it was a myelin disease. Now we're seeing axons and neurons involved. And myelin may be easier to repair than axons and neurons. So we need to stop this thing early. We thought it was a T-cell disease, a cellular immune disease. We thought all of our treatments were aimed at T-cells. Well, now we know it's B-cells. And so we want to make sure that we attack those B-cells that are causing the damage as well. And then we're seeing something called degeneration. The fancy word is apoptosis, but the cells are just dying without much inflammation, very little inflammation. Why are they dying? Because there's another process going on. And we think we can reduce that if we can treat early and aggressively. So we're trying to look at all sorts of ways to help people very early in the disease. So one of the take-home messages here, if you've got a relapsing form of MS, talk to your doctor about treatments. So now I'm going to talk about the disease-modifying therapy. And Stuart mentioned these, and I'm not going to repeat them, but I think you know what they are. We mix brand names and generic names. You probably know them by both. Like, for example, we say the word fingolimod, and the trade name for that is Gilenya. We talk about teriflutamide. The brand name for that is Aubagio. And I'm hoping that you know all that. If not, you can ask questions about it, and we can talk about it later. But they're given by different mechanisms, different doses. The one thing I will talk about is a drug called mitoxantrone, also known as Novantrone. We really don't use that anymore. I haven't given it in years because it has heart toxicity and can cause leukemia. And so it's just, the risk is too great. We've got too many other drugs. Good. So I put it here because it's FDA approved, but I don't recommend it. So now I'm going to just give you an overview of the good and the bad and the ugly. And I'm going to start with interferons, and as you know, that's beta-seron, Avonex, and Rebif. And the good news is that they're effective. The relapse data on all these drugs is impressive. It's effective. It's helped a lot of people. I've had people on these drugs 10 or 20 years. They've been totally relapse-free. They've done really well. So therefore, they are effective, and they have a long, strong safety record. We've been using some of these drugs for over 20 years. People are still on them. That's saying something. So the interferons are certainly still in the ball game. And they're something you should consider. There are fewer injections in the daily gluteramine acetate. One of these is once a week, every other day, 3 times a week, that sort of stuff. So you don't have to take as many shots. I'm going to talk about gluteramine acetate in a minute, though, for some good news. And there's long-term effectiveness data. There's over 20 years of data on people who've been taking some of these drugs. And they've done really well. People who've stayed on these drugs and been on these drugs have a remarkable safety record long-term after 20 years, and also effectiveness. These people are still doing really well. So we're really happy that we have long-term effectiveness data and also long-term safety data. Well, the cons is they don't cure the disease. They're only moderately effective. But I divide people into super responders, optimal responders, and suboptimal responders. And there's a lot of people who are super responders to this, but not everybody. And as far as tolerability, sometimes you can get flu-like side effects. It's usually transient. There's ways to deal with that. Can affect the mood. I put a question mark there because MS affects mood. It's hard to tell what came from the drug and what came from the MS. So every drug you're on can be associated with depression. That's because MS is associated with depression. So keep that in mind. And you have to monitor for liver and blood counts. So at least my patients, every 6 months, they have to get a blood count. So it'd be nice if they didn't have to have that, but I feel safer doing that. And then there's this thing about neutralizing antibodies. Again, I have a question mark. And I don't use neutralizing antibodies in my practice. If a patient's doing well, I keep them on the medicine. If they're doing poorly, I switch the medicine. If they're doing poorly and they have no neutralizing antibodies, do I care? Frankly, and if they're doing really well, they're being optimal responders or super optimal responders, I'm not going to switch medicine based on a laboratory test. Other people would disagree. Gluteramine acetate, also known as Copaxone, again, it has effective data. It works. It has, again, it's been around a long time. It has a great safety track record. It's better tolerated than the interferons. They don't have to worry about neutralizing antibodies, all the monitoring. And now they have a new product that's approved. Same drug, you only have to take it 3 times a week. So therefore, that means you've reduced over 50% of the number of shots you have to take for Copaxone. And I think it's a great opportunity to be able to take this drug with only giving a shot 3 times a week. And so as far as the cons, the same thing. It's not the cure for the disease, and we wish drugs were more effective. But the fact is, we have super responders to Copaxone, and I've been pleased to say I have a lot of those. They can cause lipoatrophy, especially women. They have little dimples in their skin around the fat area, and that's something you could see. There's injection site reactions. They can have pain and redness. Usually not intolerable, but that's something you can expect. And then very unusual, they have systemic reactions. So within half an hour of taking the medication, they'll feel sort of flushing and a little short of breath, and they're wondering what's going on. It goes away. There's never been a serious problem with that, but you just have to be aware of it. Natalizumab or Tysabri, it's a highly effective drug, and it's well tolerated. People like it. Their quality of life is better. And one of the things I like about it the most is that you have essentially 100% adherence, because you have to go to the hospital to get your infusion every 4 weeks. So you've got to go. So you can't just say, well, I'm going to quit. I'm going to take a 2-week holiday from this drug. You only have to take it once a month, but you have to take it. And the other thing I really like is they're doing a clinical trial on secondary progressive MS. So we're now starting to look at the drugs that work for relapsing MS and trying to use that in secondary progressive MS, or even primary progressive, as the case may be. And so they're really trying to help people with progressive MS. So what are the cons? Well, there is a risk of a disease that is a viral infection. It can be very serious. It's very scary, and it's called progressive multifocal leukoencephalopathy. If you don't mind, I'll just say PML, so we'll know what I'm talking about. It has an increased risk if they've got the virus antibody in the system before they start taking Tysabri. If they've had previous immunosuppression like novantrone, mitoxantrone, the drug I talked about on one of the previous slides, and the longer you take it, at least for the first few years, you may increase the risk, especially after 2 years. So it's 2 years when we really start seeing an increased risk of that. And so another con is, because you have these risks, you have to go through a lot of monitoring and stratifying the risk and things like that. It's a complex process. You have to sit in an infusion center for 3 hours a month. Actually, I haven't heard anybody complain about that, but it's still something you need to know about. And the thing that we do have to make sure you know about, if you ever stop this drug, if you say, well, I'm just going to quit taking drugs for a while, that's not a good idea. Within 3 or 4 months, if you stop taking Tysabri, you have a very high chance of having a very severe attack. So do not stop Tysabri until you talk to your doctor and go on something else. Fingolimod is also Gilenya. You know it is Gilenya. Again, it has a moderate to high efficacy rate for relapses. It was 50% better than one of the interferons regarding relapse rate in one trial. It's a once daily oral capsule. Now we've treated over 70,000 people who have gotten this drug initially, so we have a lot of experience with it now. It's not the new kid on the block any longer. It actually can reduce the progression of brain damage or brain injury or brain atrophy, we call it. In a recent study, it reduced brain atrophy, and they also have a trial in primary progressive MS. And I'm so pleased that these drug pharmaceutical companies are really trying to look at progressive disease. We won't know the answer for this probably till the end of this year. But think about how long we've waited for a treatment for primary progressive MS. We only have a few more months to wait to see if there's no guarantee it's going to work, but at least they're trying it. As far as the cons, there is a cardiovascular risk. They can have a transient decrease in heart rate. If you have heart problems, you may get a heart block. These are specialized issues. They Most people with MS are relatively young and they're healthy otherwise, but we monitor the electrocardiogram on people during the first 6 hours that we give it. We always get an electrocardiogram before we give it. We want to make sure we're not dealing with heart problems. And so far that's worked out really well. I say there's limited long-term safety data. It's only been out for a few years. So we don't know what's going to happen in 10 or 15 years, but so far we've been pleased. There can be visual blurring, something called macular edema. It occurs in 4 out of 1,000 patients, usually it's transient, temporary. But we have people see an ophthalmologist before they go on the drug to make sure they don't have it beforehand, and 3 or 4 months later to make sure they didn't develop it. And we really are careful with people with diabetes or an eye condition called uveitis. Shingles may be increased. The risk of shingles may be increased. You may need a shingles vaccination before you start this medicine. And it's a hassle. In the baseline evaluation, you need the cardiogram. You need the ophthalmologist. You have to do all this sort of stuff before. You have to be monitored for 6 hours when you first take it. That's a hassle at the time. I can tell you, people who've been on it for a few months are doing great. Don't even think about it anymore. But nonetheless, there is some hassle factor starting this drug. Fortunately, it's been well worth it for the people who've done well. Teriflunomide or Aubagio, it has a moderately effective relapse rate. It has a very good safety profile. It has positive data on relapses, MRI, and disability in all their studies. So that's really important that they're looking at all 3, and they've had good results in all 3 areas. It lasts a long time. But it's easily reversible. In about 11 days, you can give this drug called cholestyramine and take it. If you need to get rid of it, if you want to get pregnant, you can get rid of this drug in less than 2 weeks. So that's good. So some of the drugs that you give, you have to wait till they get out of the system, and this would be a long time for this drug. But so we don't have to wait. As far as the cons, it's rated as a concern for pregnancy, concern for the fetus. Now we haven't seen that in the patients who've gotten pregnant on it, but nonetheless, the animal work with a drug that's not this drug, but another drug that's like it, showed there may be some fetus problems, so we're really careful. But my recommendation is don't take any of these medicines if you're thinking about getting pregnant. Stop these medicines before you get pregnant, except for Tisabri, and don't stay off this drug for more than a month or 2 without taking something else. But I think that fetus should not be exposed to any of these disease-modifying agents, period. Hair loss, it's usually mild, it's usually temporary, and the other con is that it stays in the body for a long time. So it affects the immune system for a long time after you've quit taking it, unless you reverse it with this drug called cholestyramine. BG12 is now called Tecfidera, dimethyl fumarate, those are other names for it. And again, it's an oral medicine. It has a moderate to highly effective relapse rate data. It has a potential, it may actually protect the brain, neuroprotection. We haven't proven that yet in trials, but at least has some ways that it may be neuroprotective, which is another thing we're looking for. As far as the cons, you have to take a pill. It's twice a day. Obviously we want a once-a-day pill. You have to take this twice a day. If you take it once a day, I think you're wasting your money. You really need to make a commitment. I'm going to take this pill twice a day. Don't skimp on this pill. There's some tolerability issues, especially early on with GI problems and flushing. We're working on these right now, and most people have been able to develop ways that they can get around this, and again, they're temporary. There's limited long-term safety data. This drug has only been on the market for less than a year, and it also has the potential to reduce lymphocyte counts, the white blood cell counts in the bloodstream. So we're worried about, well, if you're reducing the lymphocytes, maybe you get other infections. We haven't seen that yet. So it looks like the lymphocyte count may go down, but doesn't appear to be having any harmful effects. Next, when to stop therapy. I'm asked this question more and more because there is managed care companies and prominent neurologists saying, if you haven't had an attack in 2 years, you don't need any medicine for your MS. So I'm going to give you my personal opinion, and I'll give other people the chance to have their opinions. As I don't know whether this is true, but I know what I do, and I feel strongly about what I do. It's a personal opinion because I don't know how to think about this. So let's say you go 2 years without a relapse. Well, it could mean that your therapy is so darn good that it's working like crazy, and you better keep that in your system because these drugs only work when they're in your system. So you would not want to stop a therapy that's worked so well that's knocked out your relapses. So why would you even think about this? Other people would say that it's no longer needed because you've probably transitioned from relapsing disease to secondary progressive disease without relapses. And so therefore these drugs are not proven to work in secondary progressive disease without relapses. So therefore it may not be working. And so therefore if it's not working, why are you spending this money? Why are managed care companies having to spend all this money to buy these drugs for you, et cetera, et cetera? And it's just not cost-effective medicine to do that. Because none of these drugs have been proven to be helpful in secondary progressive disease without relapses. And so that's the argument. Okay, let's see. Well, here's one of my concerns. If a drug is working great and I stop it, and people start getting worse again, and I put them back on the drug, sometimes it doesn't work as well. I think we're taking a risk reinstituting therapy. We need to keep people on therapy, not stopping therapy and then reinstituting. If 3 or 4 months later, 6 months later, you're starting to have attacks again, then put them back on it. That doesn't make sense to me as a doctor because it may not work the second time around as well as it did the first time. So I switch therapy if I'm having intolerable side effects, if I'm having adverse events, bad things are happening, or the disease is getting unexpectedly worse. That's the reason I stop therapy, not because people are doing well. And if they're doing poorly or they're having problems, I don't stop therapy, I switch therapy. So that's my attitude, and I end this by saying not all experts agree with me. So there's another side of this story. I've tried to explain their side as well. All right. So we've talked about the drugs that are approved. Now I want to focus on what's coming out, what's in the final stages of clinical trials. And I'll start with Plegridy. I don't know how you're going to pronounce it. It's pegylated interferon alpha. It's an interferon. It's very similar to actually Adherence, but it's given in a different way. It's mixed up differently, and it lasts for 2 to 4 weeks. So you don't have to take shots all the time, and you can give it just under the skin. You don't have to take it intramuscularly. So it's much more convenient and much less frequent. And the data looks good. It's not approved by the FDA, but they're considering it right now. So I think you get used to pronouncing this word, because I think we're going to see it around very quickly. Another drug is called Limtrada. It's also called alemtuzumab. The data on this was it was more effective than 50% more effective than an interferon over a several-year period in 2 separate studies. So it looks like it's going to add a lot to our armamentarium for treating multiple sclerosis. The issues here, it's going to require close monitoring for blood counts and for thyroid functions and some other things, because we have to make sure that we're careful with this. Part of the good news is you only take it once a year. You take a series of 4 shots once a year, 4 injections, and no more the rest of the year. So you don't have to worry about treatment. But you have to worry about monitoring. Even though you're not getting the treatment every month, you're probably going to have to get blood counts every month to make sure you're not having an adverse event to this drug. And again, we're waiting for the FDA decision. I'm hoping that will be here by the end of the year. Daclizumab is a monoclonal antibody. It's an antibody against this receptor on a cell called CD25. It reduces the immune system. It's got good data right now. It's in trials currently. The results look very good. It's not yet been submitted to the FDA, but they're also trying to study it in progressive disease. Again, I'm going to keep focusing on progressive disease today. It looks like, I think this drug is going to make it through. I think it's pretty well tolerated, and the results are good. The last drug I'm going to talk about is laquinimod. It's an oral medication that it has unique properties. It decreases progression of disease very nicely. And that's what we're really looking for, an oral pill that decreases progression of disease really well. So we're hoping that the results of the trials that are going on right now is going to be positive, and we'll be able to have this drug able to give to patients. And now what I'm going to do, and I'm going to do this very quickly, I'm going to start by telling you there are 30 drugs in the pipeline or more, and there are others waiting to get in the pipeline for MS. This is like 20 of them. And I'm going to go through it very quickly. I'm not going to go into the details of this, but I'm here. This is shock effect. These next few slides are shock effect. Wow, look at all these things that are being developed for me. They're in trials right now. They're really promising. So I'm going to go through them very quickly, and bear with me. This is the first 6. Rituximab, which is it affects B cells and knocks out B cells. We're very encouraged about rituximab treatment and its next generation of rituximab treatments, which I'm going to talk about in just a minute. Siponimod it works like Gilenya works, and we're hoping that maybe this is good, if not better than Gilenya, and it'll keep the bad cells in the lymphocytes and not let them in the bloodstream. It won't kill them, just keep them in the lymph nodes, so they don't get into the blood and then get into the brain. Tofaxin, I can't pronounce the name of this drug, but you take the patient's cells, you cleanse them up outside, and you put them back in. It's called a T-cell vaccination technique. It's being tried right now. Let's keep our fingers crossed. The statins, the anti-cholesterol drugs. There's some recent data that looks very encouraging about statins. And Tisabri, as I said, is being tried in secondary progressive disease. Diclizumab is also being tried in progressive disease. Gilenya is being tried in primary progressive. Ocrelizumab is the successor of rituximab. It's the new rituximab. It's a more pure molecule, and the data looks very good so far. Amyloidide actually talks about changing the salt and potassium channels in the brain. I'm not going into the details, but it has really good potential, and it may be helping the degenerative part of the brain. Because we got lots of drugs for inflammation, so we're looking for drugs for the degeneration part, which we think is the issue around progressive disease. So we're focusing on progressive disease today. And Idabinone, which is actually like a coenzyme Q molecule, it affects, it's an antioxidant, and it may be helpful in preventing damage. Some of the other drugs, we've talked about laquinimod, Tisabri, Lemtrada, other monoclonal antibodies, vitamin D, and other drugs that I'm not going to go into details. These are here. Look them up on the internet. You'll learn a lot about them. This is a 2-hour lecture. I don't have 2 hours, but I'm just letting you know what's going on. And then once you get past that, you say, oh, that must be all. Well, no, it's not all. Look at this. We're looking at something called mast cells. Nobody's ever heard of mast cells, but they have an effect in the immune system, and we got a drug that decreases mast cells that looks like it's going to help progressive patients. So yes, ibutylast, again, really good preliminary data on ibutylast, and it appears to have a neuroprotective. Well, let's talk about restricting salt. I told you about earlier. There is a dietary way to help control your multiple sclerosis by reducing the salt. So take advantage of it. As you increase the salt, you increase inflammation, you increase the MRI damage, you increase attacks. So you want to help yourself? Look at your salt intake. Anti-lingo antibody. Wow, okay, here we go. We're trying to figure out what to do with this myelin that's being damaged. Well, what happens is that there's this protein called lingo that decreases neuronal growth and decreases myelin-making cells growth. That's not good. So this is an antibody that knocks that out. And we know it's safe. We're waiting for the results of the efficacy part of anti-lingo antibody of this, but it's very exciting. And MIS 416, it's a whole different way of looking at it. This actually affects the innate immune system. I've been talking about B cells and T cells. They're called the adaptive immune system. This is actually the early responders to the immune system. So look this up. Transderm peptides, you take some peptides and put it under the skin. That looks like parts of myelin basic protein. And you may actually be able to take this, put it in to the patients, and tolerize the immune system. What does that mean? It dampens it. It doesn't allow them to respond to these triggers that I showed you about in Dr. Steingold's first thing. So we have the triggers, but the lymphocytes don't respond because they're tolerized. Antioxidants, things that increase brain growth factors, estrogen-type products may be very helpful. So a recent study on estriol that I got mixed results, but there's going to be more studies. NDC 1308 actually restores myelin. Exciting, isn't it? I'm going to end the treatments by talking about stem cells. And Stuart asked me to talk about stem cells, and I'm going to do that in just a few minutes. So what do we know? Stem cells are very exciting. The data is very preliminary. The foreign treatment centers are, I think, my opinion, bad news. They lack regulation. We don't know about their cells. We don't know if they're fresh or frozen. We don't know how they prepare them. We don't know their safety precautions. The scientific data is lacking, and my thought is it's not ready for prime time. Wait until we understand this better, because there are issues here that I'm very concerned about. I've had patients who have done this, and they've gotten very sick. So wait. That's my thought. What do we know? Or what do we not know? We don't know the cells. We want to give fetal cells. We want to give embryonic cells. We want to give placental cells. Do we want to give umbilical cells? What cells do we use? Remember, these cells are not from the patients. And will they have some sort of immune reaction if you put them into another patient? And will we have to immunosuppress these patients? We don't know that. But now we're starting to look at cells from the patients themselves, from bone marrow, from fat cells and skin cells. We're not sure how to prepare them. We're not sure how to make them the way we want to make them. So we don't really know yet. It's still experimental. And then once we get them, do you inject them into the brain, into the spinal fluid, in the blood? How do you give them? Until we find the answer to this, stay away from stem cells, is my feeling. We need more data. I would not go to these commercial places because we don't know their safety or efficacy status. All right, I'm going to finish by talking about one of my near and dear parts. It's called the adherence and compliance to taking medicines. Because if you don't take them, they are not going to help you. But you have to know these are not the cures. They don't eliminate the symptoms. And that but they do have help. So this is the response. Now, this is Canada. You know, those Canadians, those guys are real different than us. But this is data that tells you how serious the problem is. Over 24 months, over 50% of the patients were not adherent to their drugs. Unbelievable, isn't it? We have these drugs that work and people don't take them. Well, you have to be adherent. People are concerned about the needles. They don't want the adverse effects. They're not sure if it's really helping them. They feel depressed. So if people are feeling depressed when they take these drugs, get treatment for the depression. Don't stop the drugs. So to increase adherence, first of all, it takes a good relationship between you and your doctor, and yet it needs education, and we have to address all of your concerns. We have to look at all the other issues related to that particular individual patient. This is an individual decision, because we know that some people respond and some people don't respond. We don't know who they're going to be. Well, I want to try to get this important issue across. It's because it's one of the biggest decisions you have to make. What drug am I going to take, and am I going to stay on the drug? And then we have to talk about switching drugs. If you switch drugs, why do you switch? Well, I talked about this before. For me, it's I don't tolerate the drug, it has terrible side effects, or I'm not responding to it. And then you have to have that discussion with your doctor. And I think the way to do that, I'm going to just go through these quickly. These are the issues. we look at all these issues for each patient, trying to figure out how to start or how to switch drugs. And so as far as making a decision, I'm going to just talk just a very short minute about self-management. No. You don't want to take care of yourself. You want shared management. You want to develop a system where you work with your doctor that you become knowledgeable and you have this discussion about what your interests are. What's your perspective about these drugs? And what do you feel about them? Because if you don't buy into what your doctor recommends, guess what? You're not going to take it. So we have to work together to do this. And I'm going to just go through these because my time is up. There's a way to look at this. It's called search. And these are the issues that I suggest you address. What are the safety issues of each drug? What is the effectiveness data? How affordable is it? What are the risks? What are the convenience issues? And my health outcomes. And if we look at safety, this is just an example of some of the questions. We try to frame the questions for the patients so they know what to ask their doctor. So these are the safety questions that most of my patients ask. These are the effectiveness questions, how they ask about effectiveness. If you learn how to frame your questions, you're going to get better results because the doctor is going to know what you're talking about. So I suggest you get this. This is called a search document from MSAA, and I think you can get it online from there if you want to. Affordability? Yes, it's a big issue. Am I going to get this covered? How much is it going to cost me out of my pocket? The risk, what are the risks? This tells you how to ask those questions. And the convenience, and I'll leave this for you to Stuart will have copies of these. I'm sure if anybody wants them, he can have copies of these. And then health outcomes. Well, taking these lower my immune system, I'll have more other diseases, etc. These are important questions. And so I'm going to end with a game plan, which you'll have with the slides of that you can look at. And if Stuart invites me back, I'll talk about it in more detail. But I'm going to end with one slide. And that happiness is a state of mind, not a state of health. And remember that. And it's not what you've got, it's what you do with what you got. Jimmy Huga, the famous ski racer, had MS. He was bad shape. He took that and made a wellness and health program that helped thousands of people. He made something out of his life. Stuart has MS. He just told you that today. He's made something out of his life. He may have made more of a contribution because he has MS than if he'd have been a successful multimillionaire businessman without MS. So it's what you do with your life, not what the disease you have. Thank you very much for your attention. I can take questions.
Yeah, we're going to take questions, all right?
There were a number of questions during the talk, so hopefully you'll come forward now and talk.
Just so you know, though, I have to run around the room because we got to get you on the mic, all right? So if I don't get around the room quick enough and you jumping up and down that you need to ask him right away because you have to run to the bathroom or something, he's going to have to repeat it. So try to let me get there with the mic first. We're going to start over here, and I'm going to run around. He's only got 15 more minutes to be here, so we got to do this quick. No two questions, one question each.
Thank you. Dr. Burks, back in the late 70s, early 80s, the Weinstein Institute out of Israel came out with a major study on sodium in MS, just like you said. Following with those guidelines at that point in time, I completely cut salt out of my diet for about 18 years. Then I ended up getting Graves' disease because no one had ever mentioned the iodine. What is the best way to supplement the iodine while cutting down on salt, please?
That's a great comment. Salt, reducing salt may well be why you're out walking around running the 100-yard dash today. So I'm really pleased to hear that testimonial. As far as the iodine, you have to watch the salt. And the best thing to do, I don't want to prescribe things here, but talk to your doctor about how the best way to get your iodine. If you have to watch your iodine, thank you for bringing that up.
One in the back, please.
I have a question.
Hi. Sorry. Go ahead.
I have heard about Botox treatment and bladder control and headache control with people with MS, and I just wanted to ask you how true or verifiable or not reliable that information is for patients with MS.
It's a terrific opportunity, and Patricia's going to talk about that when I'm done. But the answer to that is yes. I think Botox injections can help headaches, and I think they can help the bladder dramatically. And there's data, there's studies to say that Botox is something that should be something you talk about your doctor about.
Before we go to the next question, I just want you all to know that Dr. Burks is going to be leaving in a little while, but Patricia is able to handle all these questions as well. And so whatever we don't get done right now, we'll be able to carry over into afterwards too. She's up first.
Okay. Dr. Burks, I had a question about exercise and brain atrophy and preventing cognitive decline or enhancing cognitive reserve. And I heard about this from Timothy Vollmer at the Rocky Mountain MS Center in University of Colorado, and I believe you spoke there.
Actually, I'm one of the founders of the Rocky Mountain MS Center in the 1970s. I ran it for 20 years, and Patricia's going to talk more about that. I'll just give you my 2 cents worth. I think it's great. I think it's real. I think exercise is really important for people, and I do think you can help the brain adapt better, much better with exercise. And I would recommend everybody who can get an exercise program. And I've not met anybody who couldn't exercise, even in a wheelchair. So there are ways to exercise. I think that data is slow to come to the attention of MS patients, and it should have come earlier.
Do you use brain atrophy as an end marker for whether or not someone's responding well to that?
Well, brain atrophy is a relatively new part of the MRI. We don't have a lot of experience with it, but the answer to that is yes, I do. I think it could be very valuable. It hasn't been part of the clinical trials, though. But I talked about Gilenya earlier, reducing brain atrophy. I think those are going to be important measurements for all the new treatments that are coming out.
Having heard what you said about stem cell, do you know any data on Meredith Vieira's husband? Because I think it's the only one in the United States where it's being done. Is that not correct?
Who's this?
Meredith Vieira. She's
Richard Cohen.
I don't know this story. Sorry, I just don't know that. There are people in the United States that are doing it. They're doing it under clinical trial circumstances for the most part. Those I approve of very much. There's a doctor in New York who has a program going on right now using this. I think that I just don't think you should go to Joe Blow down the street in Ocala, Florida, that might have his little shop there. I think those are probably not in your best interest, and that's my experience. It won't be long before we'll know about stem cells, but I'd hold off, and I certainly wouldn't go outside the United States.
Hello, doctor. I was questioning not the steroids, what you had in lieu of the steroids. Can they, for an exacerbation, would that affect your bones like osteoporosis would with the steroids?
Yes. Yes. Steroids can increase the risk of osteoporosis. You have to be very careful. You need to have your doctor work with you if you've had a lot of steroids. Taking one dose of steroids, I don't think that's a big deal, but if you're taking multiple courses of steroids, you've got to look at osteoporosis as a potential adverse event for steroids.
She was asking about the Acthar.
Oh, now the Acthar is different. It has the same effects as the steroids, but it's used, you don't get that much. And I don't know of any data that says it's associated with osteoporosis. I'd be worried about it because it has some of the same steroid effects, but it has this other effect that may be important. We're trying to figure out this melanocortin effect. So I haven't seen it with the Acthar, and I used to use ACTH a lot 30 years ago. So I think we just don't know yet.
Dr. Burks, first, you're fantastic. Thank you very much.
Thank you.
I have a question. If you have no enhanced lesions, like over the past 5 years, does that put you in secondary progressive category? I realize there's a short window for enhanced lesions, but during
I'm sorry, you're saying that if you have no gadolinium enhanced lesions, does that mean, well, Let me just tell you about gadolinium-enhanced lesions and T2 lesions. T2 lesions are the new lesions that occur then you didn't see gadolinium to begin with. Every one of those was gadolinium-enhanced at one time. You just didn't have the MRI at the right time. So if you have a T2 lesion, that was a gadolinium-enhanced lesion that the doctor didn't pick up because he didn't do MRIs every day on you.
Right, because I realize there's a short window for that. But over the past 6 years, I've never had one enhanced.
A T2 lesion or gadolinium-enhanced lesion? Okay. Those are fabulous, and I'm so happy for you. But I also have to look at how you're doing clinically, because there's a lot of inflammation in the brain that's not seen in a T2 lesion or a gadolinium-enhanced lesions. There's probably low-level inflammation going on in the brain at all times once you've had the disease. Some people may not, maybe 10% of patients don't have that, but most people do. And so therefore, I'd just be reluctant. This is a decision between you and your doctor, but I'd be reluctant to say you don't have inflammation just because you don't have a T2 lesion or just because you don't have a gadolinium-enhanced lesion. And I'd look at the whole picture before I'd make any decisions about you don't need medications anymore.
I am on Fasabri for possible secondary.
You didn't turn it off.
Yeah. Well,
and clinically, I'm doing well. So
I see a lot of people on Tasabri who have no gadolinium-enhanced lesions, no T2 lesions. I wouldn't stop it. Because my feeling is it works that well. Why take a chance?
I'm on dose 36. I'm on dose 36. Yep.
Congratulations. Yeah, the JC positive patients, that's a different story. Thank you. Thank you for bringing that up.
What's the medication that you were saying was comparable to Gilenya?
Saponamide. It's the same type of drugs. It works on different, it has a little bit different action, but it has the same overall action. And it's in trials right now. We don't know if it's going to be as good or will have less side effects. We don't know that. But we're hoping that it may be something that would be useful to us. But it's a long ways. It's not going to be acutely. It's not in the next 6 months. It's going to be a while from that. But at least we're starting to look at how to modify the current drugs that we have to make them either safer or more effective. And that's what we're doing with saponamide. But we don't know the answer to that yet.
How could you get involved in the trials?
How can you get involved with the trials? First of all, I would ask your doctor, your MS center, if they're doing this trial. They're only being done in a few places in the United States. Go on the internet. Look at who's doing the trials on the internet. Just Google saponamide and find out the trials are. Stuart?
Google everything.
Yes.
In the back, Dr. Bank.
Hi, can you comment for us on the endpoints that are used in the clinical trials for MS? I think most of us realize that the major cause of disability in MS is cognitive problems and horrible fatigue, and we rarely see those as endpoints in clinical trials. And I understand those are hard to measure, but that's what's really important to a lot of us who suffer from MS and why we're maybe not working. Do you see the pharmaceutical companies looking at these as endpoints anytime in the near future? And I know we want to think that, well, lesions on MRI or atrophy correlates to these things, but it doesn't perfectly. And I'm concerned that we have all these wonderful medicines in the pipeline, but the endpoints of these trials are always the same. Numbers of relapse, numbers of lesions, and they don't address the symptoms that we have.
That's just a great question. Thank you for asking it. It's not that pharmaceutical companies decide. The FDA decides. The FDA says, if you want to get on the market, you must prove relapses, disability. They don't even count MRIs now. And they're certainly not going to call cognition or fatigue, something like that. But what the companies are doing now is they're doing ancillary studies, secondary and tertiary outcomes. These are called patient-related outcomes, or PROs. And we're actually doing these studies. Like, for example, there was just a recent study with Tasabri that says the quality of life was dramatically better on these patients. And that's important for me. It's important for you. The cognitive issues. We're starting to look at cognitive issues. But that's not what to get approved, the FDA doesn't want to hear that, frankly. It's not going to affect them at all. So what they do is they put their money into getting it approved, and then they can do the ancillary studies. But what's happening now is they're starting to get the patient-reported outcomes like fatigue and cognition and quality of life at the same time. So we're going to see more data about that, because you're right. What the lymphocytes are doing doesn't mean much to the patients. It's how they feel and what they can do with their lives. And we need to look more closely at that. And you're going to see more and more patient-related outcomes that you've talked about involved in the clinical trials. It's not going to get them approved by the FDA maybe, but it's going to be helpful for people like me who prescribe them and for people like you who are being asked to take them. So thank you for that question.
Good afternoon. I was just curious, with people that are actively taking MS therapies, do you generally recommend shingles vaccine or not?
Would you repeat that? I missed it.
With patients that are on MS therapies, do you generally recommend or not recommend shingles vaccines?
It's an individual decision based on the drug they're going to take, what's its risk of increasing shingles, the patient's history. Like I have patients who've had shingles for maybe 2 or 3 times before, and said, well, they must have antibody. Well, I get an antibody test on those people. I watch them very carefully. But it's an individual decision between the doctor and the patient of whether you do or not. However, if, like Gilenia, which I talked about, is that if you haven't had shingles, you haven't had chickenpox, you get a vaccination. If you've had chickenpox a long time ago, you get the vaccination. Or you get the antibody first. If you have antibody, then you get the vaccination. It's more complicated than that, but I think for the purposes of this question, get the antibody if you're concerned, and if you don't have antibody, take the vaccine. And even if you have antibody, if you have a history of shingles, consider the vaccine as well, because it depends on the titer as well.
All right, I think we're out of time for the doctor, simply because I know he has a flight to catch. So I do want to thank Dr. Jack Burks for coming up here and speaking with you all today.
Thank you very much.
I want to thank all of you. I got to thank our speakers because they did such a great job today. And I also have to thank again Teva Neuroscience for allowing us to provide this program today. So again, I have to thank them. Thank you. Our volunteers, our film guy, Bill goes wherever I go. So wherever we're doing a program, it doesn't matter. He'll be there to help out, and I got to thank him for that. All right.